All right, guys, we'll get started. Welcome to EMS Challenge. We're at Birmingham Fire Station 1. If you're in the area, feel free to come out. We're here from 9 to 11. And then we have lunch and then skills lab. Um, Thanks, Birmingham, for hosting us today. I have not participated in EMS Challenge before. This was started about 10 years ago to bring more physician-led Con Ed to the area. Not continuing education, it's just education. So, yeah. Education sites are kind of logging on this, and we can give Con Ed for both nurses, EMTs, medics. We can also do physician CME, and it's all free. So, how we start? Starting like a NASCAR race, right, or a wreck. You to sleep. I like cats. If you like cats, raise your hand. Good. We have one person here that you've already passed the program. Thank you very much. You can head home if you want to. Okay, good. All right. Updates we got coming up will be in Arley, which is Sand Mountain Park, on the 4th Wednesday of June. So come out. That's out near the Gadsden area, if I am correct. But we'll have lectures and skill lab there. July, the transplant games in the city of Birmingham. We also have a transition for the new residents at UAB. So there'll be no EMS challenge in July. We'll be back in August 14th at Brims, and we'll be covering trauma scenarios. We should have our hemorrhage control mannequin out there too, that we can do chest decompression and tourniquet control. The 28th will be in Prattville. And then the 29th and 30th, we'll have a cadaver lab, which is free. And it'll be at the UAB School of Medicine. The information will be posted, and I'll have it on Eventbrite here pretty soon. We do ask that you sign up for the cadaver lab because there's only so many spots. But it'll be that Thursday afternoon and then all day Friday. And we can probably run 16 people in at a time there. If you do come to Cadaver Lab, be advised, parking downtown at the School of Medicine is challenging at best. So I would plan to be there a little bit early. So I think that's all I got. For your certificate today, if you're in person, you can scan the QR code that you see on the tables. Online, it'll be in the chat box. If all else fails, send us an email at alabamaemschallenge@gmail.com. So without further ado, we got Dr. Hubbs, one of our senior ER residents, and then following him will be Dr. Wade. So thank you for smiling.
Thank you. Can you guys hear me, I guess, before I get going? Confirmation via mic. Wonderful. Yeah, so good to see you guys again. My name's Andrew Hubbs. I'm not a neurologist, though I am dating a neurologist, so I do have some insight and can give some pretty good feedback. So this will be about neurology. I would say the biggest thing in neurology is probably stroke. We're not going to be talking about stroke today. We're going to talk about everything else. So we'll cover seizures, we'll cover more unique pathologies, and then talk about headaches a little bit too. So like Dr. Ferguson said, objectives are not super exciting, but we are going to be talking about common kind of neurologic emergencies that come to the emergency department and that you guys see in the field. The large portion of this lecture will be kind of seizure based, that being one of the more common neurologic problems that you guys see, that we see that come in. So we'll talk about differences between functional seizures versus kind of I guess organic or more life-threatening seizures. There can be some pretty interesting kind of key findings. That can be one of the kind of trickier, nuanced things to piece out. So we'll talk about that a little bit. Talk about the workup. We'll talk about status, which is kind of essentially just prolonged seizure activity. One of the again, just kind of life-threatening things that we'll talk about. And again, if you guys have questions, just let me know. So we'll start with a little case. This is like one of the most common things that I hear just kind of working in the emergency department. So we have a 27-year-old male, was maybe acting funny at home. So his buddy's called EMS. This is pretty classic as well. Takes some sort of medication, doesn't really know what it's for, doesn't know what medical history, but takes a medication, has been out of said medication for a couple weeks. So hasn't been taking that. While he's coming into the emergency department, he starts to have some kind of generalized rhythmic movements or shaking. Maybe concern for a seizure. This patient in particular, eyes are open, deviating to the right. You try to shake him, ask him questions. He's not really responding to anything. Unable to tell you what's going on. After he's done, he has this generalized shaking for maybe a minute or two. After he's done, he's still not really able to answer any kind of meaningful or having a meaningful response to your questions. So this, as you guys all know, is referring to a patient with a seizure. So what matters? So like I said, seizure being a super common thing that we see coming into the emergency department with over 2.5 million annually. So 2% of visits is not insignificant amount. Kind of looking at national numbers. These were two little tidbits, little facts that I didn't realize, but epilepsy is 7 per 1,000, which is a lot more common than I realized. And then 1% of people will have a seizure of some kind in their lifetime, or 1% of people, which is pretty remarkable. I don't know how many people are online here, but statistically, if none of us have had a seizure before, some of us may. So it's important, obviously, to kind of know what we're dealing with. So this is just, this picture here is the kind of new age. I think it was 2017 or 2018 is when they came out with a sort of new classification for seizure types. And really just the new classification focuses on more so on what the etiology of the seizure is. So there can be a lot of seizures can look very similar, but can start from a different place or have a different etiology. I have on the side here, this is more, that's more of the kind of older classifications, really. It's to me easier to understand, a little more basic, but essentially what it is. So generalized seizures is kind of your classically speaking, you have tonic-clonic seizures. That's like, when anyone in the nation hears of seizure, that's what they're thinking of. They're thinking of where you have this kind of rhythmic, kind of stiffening and contractual movements of their extremities. And then the other version of generalized seizures is called absence. It's more common in kids, and it's often described as like staring spells. But essentially, they'll have a couple 5 seconds or so where they're just kind of not responding and altered and kind of staring off into space. So those are two types of generalized seizures. These seizures, the patient's always going to be altered to some degree. Focal seizures are a little more tricky. They have these classifications of simple partial and then complex partial, which really the only difference between those is if they're altered. So if they're not altered at all, they can have just isolated, hand or arm, or isolated face is pretty common. Can be a simple partial focal seizure. These patients are not going to be altered or confused in any way. Should they be confused, then it jumps to the next classification of complex partial, but the activity could be the exact same. It could just be their hand or arm. Hard to say. The other thing to mention with focal seizures, so they can have, maybe they're and at which point they can have kind of the classic generalized shaking all over. So really just the new classification, they just kind of focus on where it's coming from rather than what the actual activity looks like. So this is like textbook classic thing that you'll see a lot of time with these true seizures. Like I said, most of them last kind of a minute or two, and oftentimes we'll have, almost always we'll have a postictal state. So that's going to be that period after the seizure where they are very sluggish, very sleepy, very kind of confused, and takes some time to come back to their baseline. And actually, with my insider neurology information, so I was reading that this postictal state can last cases. In some patients, it'll last up to 5 days. They can be kind of postictal and have some kind of, I guess, with that, they can have kind of isolated extremity weakness. So this Todd's paralysis that I have listed at the bottom here is part of this postictal state. So they have a seizure, and then they're altered. They're not back to their baseline. They're very sleepy and sluggish. These patients can also have an isolated, like maybe they're not moving their arm at all. It's been described as a very kind of classic stroke mimic for that reason. They can, maybe they're not talking, maybe they can't move their arm. A lot of people would think that looks a lot like a stroke. But that isolated weakness and the kind of lack of returning to baseline, I didn't realize, but can last up to 5 days, which is pretty crazy. Most patients, it won't last that long, but the other sort of classic findings, urinary incontinence is a big one that I see, and then I would say that's probably more common than tongue biting, but you can see tongue biting as well. And this picture here, textbooks will tell you kind of the classic location is the lateral tongue. I'm not entirely sure why, but for whatever reason, that is where the teeth like to strike. So yeah, just kind of big things that would kind of clue us into a true seizure. So that's a seizure. That's just our kind of stock image there. And I also, full disclaimer, I don't read EEGs, nor can I read EEGs. But so in talking about status epilepticus, so this is, again, we have our kind of classic seizure presentation. Someone who's like convulsing, they're having kind of flexion and extension and contractions of their extremities and altered, lasting a couple minutes. If it lasts longer than 5 minutes, it is then classified as status epilepticus. So this is when we get into our kind of more emergent, kind of continued troubles with seizure. The other sort of formal definition would be having two seizures without a return to baseline. So you have one, still kind of confused, maybe still have some weakness, then have another seizure. Are kind of our two classic definitions for status epilepticus. This is a big deal. This is certainly an emergency. A lot of times these patients are going to be ones who, they are altered and they're not able to protect their airway, and ones who end up getting intubated and, put EEG stickers all over them and to figure out what's going on. With that being said, so again, classically, we think of the convulsing with seizures. You can have a patient that's initially, maybe that is what's going on, but this whole, and I kind of harp on this like back to baseline thing is super important with these seizure patients, because they actually they don't have to be convulsing; they can still be seizing. We call them kind of subclinical seizures or non-convulsive seizures. But the only way really to know is with the EEG monitoring to know if they're truly still seizing. But it can be tricky because they can initially have kind of convulsions and maybe you give them some benzos and it helps, but they're not back to baseline, and so it can be a kind of tricky thing. So here are some things that can happen, some reasons that we care about status epilepticus. Like I said, they can be convulsive, they can also be non-convulsive. The big one to mention, I think, is aspiration pneumonia. Patients get very, very sick with aspiration pneumonia over the course of 24, 48 hours. With these patients, they're very, very altered. Like that's that's why I said that they, a lot of times will get intubated to prevent aspiration pneumonia. They're not able to protect their airway, and that's the last thing we want to do on top of they're already having, trouble with seizure activity. Rhabdomyolysis. So this basically, the reason that this happens is a very similar kind of pathophysiology to someone who uses methamphetamines. It's kind of, it's the flexing and contraction of all their extremities for an extended period of time. So, I know all you guys have seen, someone who does methamphetamines and, come in, they're flexing and going crazy. And ultimately, some of them will have an elevated CK, and we will diagnose them with rhabdo. Similar thing here. So, if their body is just, I guess the big difference being, these patients did not use methamphetamines. So, or I guess they could, but a lot of times they're not. So same kind of deal. They are, they just have those extremities, like all their muscles are contracting, and their body's working hard, and can ultimately release some CK and cause rhabdo. Other things you can get is a kind of lactic acidosis. You can get arrhythmias. Shoulder dislocation. Classically, these patients will have posterior shoulder dislocations, which posterior dislocations, really the two big things that are described in textbooks are going to be seizures, or people who were electrocuted. So it's a very forceful, it requires a very forceful mechanism to posterior dislocate your shoulder. Or just kind of a freak accident. Sometimes, like athletes, you can see will have just the the way that they get hit or whatever it may be certainly can cause it too. But yeah, and this is just an X-ray here of what a kind of your classic aspiration pneumonia is going to look like, and that's also sort of a classic location when they aspirate. A lot of times they're lying back, so it doesn't necessarily go to the base. It can go in one of the higher lobes at the bottom. So that would be kind of a right upper lobe near the base of the right upper lobe. So going through kind of common triggers for seizure activity. We'll just go kind of through these one by one. Electrolyte derangement. So the big ones are going to be sodium and magnesium are the ones that we look at. They're going to, both of those being low are going to be a lot of times what can trigger seizures. Metabolic abnormality. The big one here I just wanted to mention is glucose. Being hypoglycemic can be a trigger as well for seizures. And something that we do all the time, and sometimes we do it so much that we forget that it can cause very, very serious presentation. Something to mention there. Drugs and toxins, another super common one. The most common, I feel like, just anecdotally, is cocaine use. A lot of times will be kind of the trigger that I've seen in the emergency department for seizure activity. Infection can be very broad. So this can be urinary tract infection. This can be a pneumonia. Really anything that kind of is a systemic infection can alter your seizure threshold and put you at risk for seizures, or anything that causes if you have a temperature that's, you're getting into 102, 103, 104. Those are going to be things that also can cause seizure. The other big one to mention is meningitis can be a very classic kind of infectious cause of seizures, especially in your kind of younger patient population. So when you're teenagers, you're patients that are in their 20s, that's going to be common. And then also in immunosuppressed patients. So a patient with maybe a cancer history on chemotherapy, maybe a patient with HIV who's uncontrolled or not on medications. Those are going to be things to keep in mind that maybe it's actually meningitis. Tumor. So this is, we will a lot of times get almost always get a CAT scan of someone's brain if they come in with a first-time seizure. And this is one of the big things we're looking for. Just make sure it's not a large mass that's ultimately causing the seizure. A lot of times with tumors, you would expect there to be kind of an isolated kind of focal neurologic deficit based on where the mass is. Not always the case. And you would also think that it being in a specific location would cause a kind of a focal seizure. But these patients also can present with the generalized kind of tonic-clonic nature. Other things we look for: vascular disease, so AVMs or arterial venous malformations, which is basically a congenital abnormality of it's a conglomeration of kind of arteries and veins that kind of were malformed. It's really just any sort of abnormality in the brain can cause seizures. Subarachnoid hemorrhage I have on here. Also to mention is subdural and epidural hematoma. Any blood on the brain is going to make that brain tissue kind of hyperexcitable and put them at risk for seizure. And then ischemic history as well. So the one thing to mention here, this is going to be someone who's had an infarct in their kind of in the cortex, less so. Some people have maybe they've had a cerebellar stroke. Cerebellar strokes really don't actually put you at risk for seizure. It's really just anything kind of across the cerebrum or in the kind of our more prominent areas. Medication noncompliance, that's probably the biggest one that I, again, kind of anecdotally, but one that I see most of the time is, someone has a seizure history, they're not taking their medications, they ran out or, can't afford it, or for whatever reason, they're just not on medication. Preeclampsia is another one. This is going to be someone, if you have a patient who's, they've passed 20 weeks of gestation, maybe they've had hypertension or high blood pressure in the pregnancy, those are going to be things that maybe we start thinking about, maybe eclampsia. And this can also be in the case, maybe they've already given birth, maybe they're a week out and they come in with a seizure. That would also be, they'd be within the timeline to have an eclamptic seizure. And then alcohol withdrawal also is a super classic, fairly common reason that people come in with seizure. This is going to be our, textbook will tell you it's, kind of somewhere between, getting into 12 hours, 24 hours, 36 hours after the last drink is going to be a lot of times where our seizure window is. A lot of times it's after they are having maybe some visual hallucinations before they go into kind of full-on DTs is kind of classically where the seizure window is. I circled this one because that's one I see the most. So diagnosis. So when they do come into the emergency department, a lot of these things we're getting to evaluate and see if we can find what the trigger was that we just talked about. So point of care glucose, again, that's probably the easiest, best thing to do kind of right off the bat. If they have low blood sugar and we have our answer, then that's fantastic. We always get urine. With that, we're looking for urinary tract infection. We're looking for evidence of rhabdo on the urinalysis as well. Maybe they'll have some blood or protein. Always getting a pregnancy test and in a female that's kind of within the proper age. And then a urine drug screen is also what we're doing with the urine. CBC, really, everybody pretty much gets a CBC. I guess really the big thing we're looking for is maybe an elevated white count or something that would maybe suggest an infection. Maybe they can have more insidious infection brewing that, see what their white count looks like. BMP, we're looking at electrolytes and or evidence of maybe kidney injury. So that's like going back to kind of rhabdo, but mostly looking at electrolytes, making sure their sodium's certainly several reasons, but I think the one thing, so when I was reading a little bit about this, I can't say that I've had a good case to describe this, but you can have a cardiac arrhythmia and syncopize or pass out or whatever it may be, and the story can sound a lot like someone who had a seizure. So that's we definitely don't want to miss something like that. We don't want to miss someone who has a congenital abnormality that they actually just have a life-threatening heart problem, but we don't want to just chalk it up to seizure. So EKG is really important for that reason. And then, like I said, the first time seizures, they're getting CAT scans of their head. We're looking for a mass of some kind, some sort of malformation. AED, so our anti-epileptic drug levels. There are only 2 in the emergency department that come back in a timely fashion. At least at UAB. So what we'll check a phenytoin level if someone's taken that at home, or we'll check a valproic acid level or a Depakote. Those are really the only 2 that are going to come back quick enough to where we can maybe adjust our medications if they're low. Otherwise, it's something that maybe we'll draw for the clinic, but not something that otherwise will help us in the emergency department. LP. So this is going to be the pursuing a lumbar puncture is really going to be, if we have someone who's immunosuppressed, maybe they're, HIV patient not on medications, or maybe someone who's on chemotherapy who maybe won't kind of mount a proper response to infection. These are going to be the ones we're worried about, maybe a meningitis, and we'll talk a little bit about meningitis later too. But those would be the patients that I would consider doing an LP for sure. MRI is not something routinely that we do. If we find a mass or something strange on the CT head, we'll maybe consider it in talking with neurology. But otherwise, not something really that is going to help kind of us. And then EEG. So this is kind of going back to that status. If they're having prolonged seizure activity, this is where we're going to put all the stickers all over them and make sure they're not still seizing, whether they're convulsing or not. That's really the big case there. Sometimes we'll get like a spot EEG. You can get like a 15 to 20 minute EEG in the emergency department. That's going to require going through neurology as well, talking to them to read it, because I don't know if anyone here can read EEGs. I cannot read EEGs. So, Though I do know this this here, when you start to see kind of the kind of crazy brain activity is seizure activity. So we have the little spikes are kind of evidence of maybe a seizure that's about to come, and then seizure activity. So treatment. So this is going to be the big thing for us, the big thing to focus on. So ABC. So airway, breathing, circulation. As with many things in emergency medicine, that's kind of our priority. With these, and then if you can lay them on their side or whatever, maybe just if keep them safe while they're kind of the seizure activity is going on. And then as far as treatment goes, the big thing is going to be, I guess the first point, decision point is going to be if we have IV access or not. I personally, I'm a big Versed fan. I think it's ultimately kind of comes down to kind of how comfortable someone is with these various medications. They all do the same thing. They all work the same way. I just personally like Versed. So 5 to 10 milligrams IM. I usually, I'll try 5 IM and see if it works. If it doesn't work, you can always give a second. The kind of tricky thing is you want to stop the seizure activity, but you don't want to give them so many or such a heavy dose that you're having to intubate them right away because they're not breathing. So that's kind of the fine line that we dance between. But with any of these, whatever your benzodiazepine of choice is, kind of the standard recommendations are going to be, you give a dose of benzos, whatever. Say we do Ativan, we give a dose of Ativan, doesn't work, we can give a second dose of Ativan. If they're still seizing after that second dose, that's when we move on to other therapies. So what I personally go to next is Keppra, and I just have kind of the dosing recommendations up here. Kind of standard recommendations will take Keppra or phenytoin, probably the two more common second line, and then third line as you go down. There are a bunch of medications, all of them work very well. One that's not listed here and really not part of kind of ER recommendations from what I can tell, but neurology says that lacosamide or Vimpat is the trade name, but that's also the two big reasons is because they have very, very low side effect profiles. So all these other medications, so phenytoin, valproic acid, and phenobarb, all can, depending on what the patient's medical history is, if they have liver disease, if they have kidney disease, can I don't know, kind of push you in one way or the other. But Keppra, is pretty much, generally speaking, good for everybody. So that's why I like that one. And then I simply included a few pictures here. So the top picture is our home version, essentially, of diazepam. So this is going to be our rectal diastat that a lot of families know how to use. A lot of families will report, yeah, we gave the diastat, and that's what that is. That's essentially just our home variety of diazepam. And then the bottom picture is Valtoco, is a fairly new medication. They're prescribing it left and right over at Children's. It's essentially the same thing, but this is just an intranasal variety. So I guess people like the intranasal more so than the rectal, from anecdotally. So any questions about treatment there? So other things, so these are going to be our more specific seizure causes. So sodium being low, we're going to be giving hypertonic saline. If they need sugar, give them sugar. If we're worried about, this is going to be our, eclampsia is going to be our pregnant patients, or maybe someone who just gave birth a week ago. These patients will get magnesium relatively quickly. It's usually 2 grams or so over 5 to 10 minutes. And then pyridoxine. So this is a more kind of nuanced, rare treatment, I guess, of seizures. And this really would only be considered in someone who's got a tuberculosis history, who is on a medication called isoniazid. But I don't know that I'll ever see this in my career. Hard to say, but I have not yet. The treatment for that's pyridoxine or vitamin B6. And then, if their temperature is 106, 107, and that's why they're seizing, then we'll cool them off. So this is the chart that I was telling you guys about that has some features that would make us, think more of kind of true epileptic seizures versus PNES is going to be our psychogenic non-epileptic seizure. So this is our more functional, non-life-threatening variety of seizures. So the up in the kind of timing category, I thought was pretty interesting. And I've certainly noticed with more people around and occurring specifically in the physician's office. Like I don't know how many times a patient will come in after a seizure. They had a seizure in the field somewhere. It was a true seizure, and I really have no way of knowing outside of what I hear from you guys or what I hear from family or maybe that's it. Maybe they don't seize again, and those a lot of times are the true seizures. It would be I guess it would be a particularly special coincidence, if they maybe thought a true seizure was coming on and were able to get into the hospital quick enough to have a true seizure, because it really, the true seizures don't wait for a doctor to be in the room or whatever it may be. So, a lot of times with the functional seizures, they'll start having seizure activity when they get there in the room when there's a bunch of people around. It's kind of interesting. Another big one is kind of the waxing and waning. Maybe they'll have, and we'll see if we get to it, but I have some links at the end just to compare the two. But waxing and waning is a big one with functional seizures as well. And it's different than, so I know with kind of status, we talked about having a seizure and then not having seizure activity, but not back to baseline, and then having another seizure. This is different. This is the same activity, maybe they're kind of shaking a little bit. It gets more severe, then it gets less severe, then it gets more severe, less severe. A true seizure is not going to change that much. You're going to see the seizure activity, and that's what it is. So those are pretty interesting and kind of helpful, I felt. If at any point they're talking to you during the seizure, if they're answering questions, a lot of times if they're making noise, like these crying, whispering, stuttering types of things, those are going to be more towards functional seizures and not true seizures. They should not be able to answer questions while they're having a seizure. And then the other big one is the eye, looking at their eyes. So eyes being closed. We think a lot of times with functional seizures, a lot of people expect and think, and maybe even if it's subconscious, but I think that when you're seizing, your eyes should be closed, which is not actually the case. A lot of times their eyes will actually be open, and maybe with some deviation as well. Now, with all this being said, there can be some crossover. One of the super tricky things is that 25% of patients with a diagnosis of functional or PNES, the psychogenic seizures, 25% of them will also have true epileptic seizures. So it can be a little tricky, and we certainly have to use our judgment. But and then we'll see. Yeah, those are the big things that I wanted to mention. The fencer's posture with real seizures. What that is essentially they will have they'll have like we'll say the right arm. Could be either, but they'll have some kind of flex, or they'll extend their arm, I suppose, in flexion, but then they'll kind of extend their arm. Their other arm will kind of curl up this way, and then they typically look towards their arm that's extended as well. It's what's classically called the fencer's posture. It's not in every seizure, but if you see that, that's pretty safe to say that's a real seizure. I think those were most of what I wanted to mention there. Yeah, we'll see if we get to the videos. The side-to-side head movement with PNES is pretty classic. Does anyone have any questions about that? Education pages from various hospitals, and these seem to be kind of the most common things that I was seeing as what families were being given. This just knowing about what their education says, and if maybe we need to educate more, I think it's pretty helpful, just so we have so much contact with them. But really, the big things that they mentioned, so they mentioned kind of loosening tight clothing. A lot of these are trying to prevent further injury. It's really nothing or not a whole lot to do with the actual seizure, but just preventing something else from happening. As we mentioned before, we try to lay them on their side. The big reason we do this, if they do vomit, we don't want them to aspirate all of that and get very, very sick. So that's one of the big reasons that we put them on their side. If they're standing or in a spot where maybe they're going to fall and hurt themselves in that way, you can try to lay them down as safe as you can. The Alabama law is that seizure patients must be seizure-free for 6 months before driving or operating a vehicle. Interestingly, physicians are not required to report patients that come in with seizure activity. So I tell people, you need to see your doctor. You cannot drive a vehicle at this time until we can figure out kind of what's going on, what's causing your seizures. Just as, for obvious reasons, that can be very unsafe. If they go home and drive a car, have another seizure and wreck. And so, not only for them, but for someone else as well. And then a lot of these patient education pages will say to call 911 if the seizure lasts more than 3 to 5 minutes, if they don't wake up, if they have two, if they're pregnant, or if it occurs near water. That's another big one too, especially with it being summer. Patients with seizure histories, just mentioning to them, if you've been off medications or if you've had a seizure recently, you really shouldn't be swimming either. That you're at very, very high risk for drowning if you have seizure activity while you're in water or near water. Those are kind of the big ones to mention there. Does anyone have any seizure related questions? Or I guess anyone online? So next we'll have kind of two more unique neurologic, maybe more rare neurologic issues. The first one being Guillain-Barré. So this is acute immune mediated demyelinating polyneuropathy. So basically what this is someone will have an infection. So say it's a respiratory infection. A lot of times classically it'll be like a bloody diarrhea that they had a week ago. And then they start to develop mostly weakness, but they can also have some sensory stuff, but mostly weakness that starts in their toes and then their feet and then their legs, and it just kind of rises. So that's what this definition is describing. A classic offender, the med school classic test question answer is Campylobacter jejuni, which is basically just a viral diarrhea, viral cause of diarrhea. So that's probably the most common. I've seen 1 or 2, maybe 2 cases during residency so far. So 2 in 2 years, only 100. It's fairly rare. 100,000 cases worldwide. This can be actually a very tricky kind of thing to diagnose as well. So classically, this is going to be something, like I said, it starts in their toes, and then over the course, it's quite variable, but it can be from days to weeks. Rises, the weakness starts to rise. And I meant to take this out. I was told it's extraordinarily rare for this to start near your fingertips. It always starts in your toes. Reason being is it affects the longest nerves in your body first. So unless someone, I suppose, has longer arms than legs, which possible, but anyways, a lot of times it's going to be in the toes. Progresses over days to weeks, usually at about 4 weeks. Maybe they're starting to have trouble with breathing as well, and that's going to be the big reason why I wanted to mention this is and why it can be an emergency is maybe someone doesn't go see a doctor and they have this and this is what's going on. If you have delayed onset or maybe we were unable to pick up what's going on and then it rises all the way up to approaching their diaphragm and lungs and heart, and that's when they're going to start to have trouble. They're going to start to have breathing trouble. 70% of these people will have again, kind of heart and lung territory. This is a clinical diagnosis, so history being very important here. You can get a lumbar puncture on these patients. There are some, again, like test question, textbook findings. The big thing, they're going to have elevated protein that can just kind of help clue you into what's going on. And then complications list here. So really just the big one again being kind of respiratory problems and cardiac dysrhythmias. So once that rises to heart and lung territory, that's when we start to have a little bit of trouble. So up to a third, from what I was reading, up to a third of these patients end up needing intubation or respiratory support, which is why I wanted to mention it. The other thing to mention, so when we do intubate or go to intubate these patients, we try to stay away from succinylcholine or RSI. I have a chart here. It's kind of small. I'm sorry, it's small, but these patients are at very, very high risk for developing life-threatening hyperkalemia with succinylcholine. That's one of the indications, or excuse me, contraindications for using that medication. Reason being, basically, it's the way that the nerves and receptors work, and you get a huge efflux of potassium when Sux is our depolarizing drug. So when that depolarizes the area, you just get a ton of potassium release. And I actually have seen this can also happen with ALS. I have seen someone give succinylcholine in a patient with ALS. And you could see on the monitor within probably 20-30 seconds had the classic like hyperkalemia sine wave. It was impressive. And then after we gave him calcium, he improved within another, I don't know, 30 seconds. It was very, very quick, but certainly a big deal and something to consider if we're going to be moving towards that. And I think a big reason, honestly, why a lot of these patients do get intubated is because of that delayed recognition of what's going on. Because it can be a weird story. Maybe they don't really even know what's going on. A lot of people, I personally probably wouldn't be able to give a very good timeline either. So I can't fault anyone, but getting an accurate story and trying to figure out what's going on can be tough. And if they don't go see anyone for some time, it can really progress fairly quickly. Another thing we get, it's called a NIF. This can kind of help determine if they're having trouble breathing or having some respiratory dysfunction. Basically, all that is, they more or less will take a straw and have them, and how well they can do that is essentially what we're testing. And we use these numbers as kind of a measure of how well they're able to kind of suck in. These patients ultimately will be coming to the hospital and getting plasmapheresis or IVIG. That's a more nuanced kind of neurologic thing that we don't do a whole lot of in the emergency department. Yeah, I think that's what I want to mention there. So that is one more rare thing that we see. Another one is myasthenia gravis. This is probably equally as rare. I don't know the numbers, to be honest, but this is somewhat rare as well. This is going to be our patients. So basically what this disease process is, essentially an autoimmune issue where they, with any muscle contraction, you have nerves that go down to your muscles. Your muscles, your nerves say, muscles, you need to work and contract. With this, at that connection, antibodies have depleted your receptors and whatever may be, and kind of impair that connection. So these people will start to have muscle weakness with sort of increased repetition. So they'll have like fatigable muscle weakness, basically. More common in women in kind of 20s to 30s, and then it's a later onset in men. Associations with this, thymoma. So that's basically just a thymus gland, that we have as children that typically, regresses in a lot of people. Sometimes you can have persistence of that, and this can be associated with myasthenia gravis. Also lymphoma, and then autoimmune disease. So this is really just the, with any autoimmune disease, if you have one, you are at risk, for whatever reason, maybe your immune system is hyperactive, or I'm not sure there's a great answer as to why it happens, but you're certainly at risk for having other things going on. So, a patient with lupus or rheumatoid arthritis, maybe we're starting to think about, oh, okay, maybe this could be going on as well, since it does have the kind of autoimmune feature to it. So this is going to be, again, this is a primarily involves weakness. So this is going to be a skeletal muscle issue. And this is going to be something that, it's going to be worse at night, better in the morning, because as they just have muscles that fatigue very easily, very quickly. It's going to be something that if they take some time and rest, that their symptoms should be better. They should be able to use their muscles kind of normally. And then it can be asymmetric as well. A lot of times this is going to be kind of, if you contrast it with the Guillain-Barré, which starts in your toes, a lot of times this is going to be proximal muscle weakness more so than distal. I have a picture here of the eye. So almost 80% of patients that are having or that have myasthenia gravis will have ptosis, which is basically just this kind of lid lag picture as described by the before photo, but they'll have ptosis, and the theory is that muscle works a lot kind of throughout the day, so it very easily fatigues with this when they have trouble with that impairment or with that. So there's something called an ice pack test, which is what this picture is basically portraying. So basically what that is, it's kind of interesting. It's just kind of a fun little bedside test. But if someone has ptosis, they have this lid lag, you can have them hold an ice cube on their eye for like 3 minutes to 5 minutes, and then afterwards they should look like this. So it should improve after the ice cube's been on there for 3 to 5 minutes. And there were a couple theories as to, I'm not sure that it's been determined as to actually why this helps. But it's a pretty classic myasthenia test, and a few theories. The one that made sense to me was that with the colder temperatures, it basically just decreases the metabolic rate, so the muscles aren't working as hard, and with that, the muscles are able to kind of work appropriately. So it's kind of an interesting little test. I've never done this, but I guess I could. Why this is an emergency, similar to Guillain-Barré, with that one we were worried about once that virus, or once they start getting trouble with their diaphragm, heart and lungs, they have trouble breathing. Similar with these patients, they can get what's called a myasthenic crisis, where they have respiratory dysfunction, they have trouble breathing as well. And this is, this can be very scary too, because again, it's a fatigable illness. So if they're working hard, and the more they breathe, the kind of worse off that they're going to be. A lot of times this is going to be in the setting of maybe they have something else going on. Maybe they have an infection of some kind that triggers a crisis. Maybe it's a new medication they just started. They just had surgery. They're pregnant. Pregnancy and infection probably would be kind of the more common. I've seen a few cases of this as well. One of them was pregnant. One of them had an infection. So, but I did put stars at the bottom here. I also wanted to mention, just because someone says they have a history of myasthenia gravis does not mean that's what's causing their shortness of breath. We still have to keep in mind, our pneumonia, our PE are more common reasons for someone to come in with shortness of breath. But they can also go hand in hand. The good news is, for a lot of patients, maybe we're worried about invasive modalities. So our BiPAP and high flow, BiPAP being probably better for work of breathing really than high flow, is going to be the treatment, at least initially, for until we can do steroids and IVIG and some other things for them. But for our purposes, it's going to be BiPAP. And we check FEC in these patients, as well as that we do the kind of inspiratory test as well, to see if they're able to kind of truly breathe like they're supposed to. So that is those. That's all I have for those two more rare disorders. And then we'll kind of jump back in. So seizure being common, two pathologies in the middle being rare, and then now we got headache, very common. So 90 to 95% of the time, headaches that are going to be coming in, maybe not quite that high, or maybe higher. We'll say 90% of the time. Patients are going to be coming in, they're going to be having, tension, cluster, migraine, viral illness. A lot of times it's going to be something that's not serious or emergent. We'll go through each of the kind of emergent causes sort of one by one. They're not all deep dives by any means, but should you guys have any questions about any of them, certainly let me know. So we'll talk about hemorrhage, we'll talk about subarachnoid, subdural. We will talk about meningitis for CNS infection. We'll talk about a little bit about brain tumors, venous thrombosis. Carbon monoxide is, can be a particularly interesting one, an important one for us. And then glaucoma and temporal arteritis. That one's a little more rare as well, but we'll finish with that. And then I have some, I don't know what timing wise, but have some videos if we have time. If not, then that's okay. So when we talk about headaches, these are going to be our red flag. If patients are mentioning these, if it's a new onset, we'll try to figure out what's going on, maybe do a deeper investigation. Especially if it's new onset in someone who's elderly. If you're 65, 70 years old, you should not be developing to pay attention to. Certainly if they have anything abnormal on their exam, if they are, they said the headache was, at its most severe, it was terrible, worst headache of my life when it started, that's when we're going to start thinking about maybe a subarachnoid hemorrhage or a bleed. So that's certainly a red flag. Immunocompromised, again, that's when we're thinking about, maybe meningitis. Multiple people in the same house. So carbon monoxide, if everyone in the house, in theory, should be having trouble. If one person's having trouble and that's what's going on and that's what's causing their headache, other people should be having trouble as well in the same house. Pregnancy and clotting disorders is when we're thinking about kind of the venous thrombosis. They could be at risk for that when they're hypercoagulable. And if they're having trouble with vision, that's typically a concerning feature. You can have ocular variety of migraines. But with eye pain in general, you should be, that will raise an eyebrow and we'll do a little digger deeping. So going through one by one here. So subarachnoid. So this is going to be, right when it started, whatever they were doing. Maybe they were sitting on the couch. Maybe they were exerting themselves. Maybe they're cutting the grass or something. 20% or so are doing something and then have this sudden headache that's terrible. And in my experience, a lot of these, when it's serious enough, you can maybe tone their headache down a little bit, but they will never say, oh my gosh, my head doesn't hurt at all anymore, in my experience. Very, very severe. And this has a pretty, quite a high morbidity mortality to it. A lot of these patients will be very nauseated, if they're able to talk to you. Sometimes they'll be, comatose or altered or, but they will have nausea, vomiting, worse pain with light a lot of times. The crazy thing is 50% of these can have a totally normal neuro exam. And then I have a picture here. So the white is not supposed to be there. So all that's blood. That was taught to me as the star of death. So that's a pretty ominous, that's a bad subarachnoid bleed right there. That's someone who's probably, they're probably intubated. I would say that's pretty high likelihood they're intubated. They weren't able to give any history. They were altered from the get-go. They had a low GCS from the get-go. So this is called a Hunt Hess. This is just something that we use to sort of classify these subarachnoid hemorrhages that come in. It's called a Hunt Hess grading system. But if you notice, like I said, the mortality is very high. Even someone with a mild headache and they look fine, they're already at 30% mortality. And then once they develop a neuro deficit, so maybe they're having some arm weakness, their mortality jumps to 50%, which is, I know I'd mentioned this, I guess, last week with this, talking about strokes. We talked a little bit about this, but the mortality is just crazy, crazy high. So that image on the last page was, they're probably a 4 or 5. So that image, they're at 80, 90% mortality. That's a big deal. So next one here, we got subdural. So this is going to be, again, kind of the white around the periphery of the brain there. That's our subdural. That's not supposed to be there. And then you can also appreciate some shift with this one in the image as well. So those ventricles should be in the center. There should be a straight line kind of between the two. This a lot of times is going to be someone who, had a fall. Maybe it was a couple days ago. Maybe they've had a chronic subdural. Or maybe it just happened. Elderly are going to be at risk. Our alcoholics are going to be at risk. Reason being, so with those two, in those two patient populations, you can get some some brain atrophy, essentially. And when that happens, the veins that are connecting the edge of the skull or the skin to their brain really start to stretch out and become very easy to shear or rip. So those two patients are certainly at high risk. And then in the age of Eliquis, everybody seems to be on Eliquis these days. So that's another patient population who's getting subdurals quite often. So that's a lot of times that was our first question. Someone comes in with a fall, they say, are they on blood thinners? So certainly something to keep in mind. Next one being meningitis. So again, these are going to be, on chemotherapy, maybe uncontrolled HIV or advanced HIV or AIDS. These patients, and they may not mount, a proper response if they have, pretty much no immune system. If they have a very advanced case of AIDS, this can be a subtle presentation, but classically, a lot of times they will have fever. Their neck will be extremely stiff, and the true neck stiffness, they're gonna have trouble like turning their head to look, at 90 degrees to look at the wall. It's gonna be very, very stiff, kind of classically. The light will bother them. I look in their pupils always, and that will bother them. A lot of times, and this is sort of kind of bug or bacteria dependent, but with some of the bacterial meningitis cases, they can have a pretty impressive rash. And those are going to be the ones where, the textbooks will tell you that the military and college students can be at high risk. It's really just anyone who's kind of living in close quarters. It's just very, very contagious. So, one person gets it, everyone's at high risk who's in the same sort of living quarters. Seizure presentation of these is 25%. A quarter of them also are having kind of a focal deficit. These are just some exam maneuvers that we do oftentimes in the emergency department. I like the Brzezinski's better. Basically, what we're doing in both of these tests, all it is you're manipulating or kind of stretching their spinal cord or meninges and seeing if it hurts. That's basically what these tests are sort of looking at in conjunction with their neck and their legs. Is typically what we're looking at there. So next we're going to go to brain tumor. So this is going to be, again, our first time seizure patients, this is what we're looking for. It's one of the big things. You would think it would be a unilateral headache a lot of times with these patients. If their mass is here, you would think they'd have a headache right here. Not always the case. They can have a very generalized, or sometimes it's just hard to describe. And then the other reason they may have sort of bilateral or just a diffuse headache is these patients are having increased pressure because of the mass. So you'll find a lot of times it'll be positional as well. So anything that kind of increases, bending over, classically to tie your shoes, you're getting a lot of pressure to your brain there. That's going to make your headache worse. When you're lying down all night, what we do to decrease intracranial pressure is raise the head of the bed up. So if you're lying down flat all night and your headache's a lot worse in the morning, that can be indicative of increased pressure as well. And that's when we start to think about things like this. Only 8%, this was like really crazy to me, is only 8% have neurologic abnormalities. You would think something this large, and this one very well could. This is just a dog photo, but you would think, with a mass being in a very specific spot in the brain, they would have some sort of deficit that you would appreciate, but only 8% really have a deficit. So again, that's why very important for seizures too. So venous thrombosis. So this is going to be these are our pregnant patients or anyone who has a clotting abnormality. So if they're on birth control, that puts you at high risk for having clots. If you just had a recent surgery, you're at risk. If you have if there's a family history of like a factor V Leiden is a kind of a classic clotting disorder, but some people just say, factor V is kind of it's fairly common that impressive amount of red blood cells, so that there's just so much in there that it just makes it kind of viscous and hard to flow properly, so you can be at risk for clots. These people have vomiting a lot of times and or seizure, but vomiting is pretty classic with their headache. The image, so image A, that's more of a nuanced kind of radiologic finding that the radiology residents and or attendings will identify. But on B there, it's pointing at what's called an empty delta sign, and that's just kind of an interesting CT finding that's classic with these, but otherwise nothing to worry about. Carbon monoxide. So this is classically will be fall and winter times when people are using heaters, or maybe a wood burning stove or a heater inside without proper ventilation. So should that be the case, we can get carbon monoxide poisoning, and people plus minus having a detector that's working well. And again, if one person in the house is having daily headaches and trouble with this, and there are other people in the house, I would be, our suspicion goes way up if several people in the house are having trouble, especially if none of them have headache histories. So carbon monoxide, so odorless, colorless. These people can be altered. They can just, a lot of times they'll just describe, I have no energy. They'll be just very irritable with that headache. Sometimes it can be bad enough to where they can get seizures. They can be ataxic or have trouble walking. Kind of hard to say just based on the degree. These patients, their pulse ox is going to be normal, just the way that the carbon monoxide takes over the hemoglobin. The pulse ox on their finger is going to look normal, so that will not deter us for investigating carbon monoxide. We'll have to this is someone will get a venous gas with a carboxyhemoglobin on it to look at it. And looking at carboxyhemoglobin numbers, so smokers, a lot of times we're starting to get worried about carbon monoxide poisoning when we get in the range of higher than 10%, kind of 10 to 15 is where we start to suspect that's what's going on. Maybe even less than that in non-smokers, but smokers can have a carboxyhemoglobin as high as 10%, which is quite impressive. Basically, what we do for these patients is give them oxygen, and that should help them quite a bit. We do also over at UAB, we have for the cases that are very severe, we can take them to the hyperbaric oxygen chamber. So people who are altered or confused, or they syncopize, they have seizure, coma. Pregnant patients, if they're greater than 15, that can certainly be bad for baby. So if they're having numbers greater than 15, we will talk with our hyperbarics people about that. And then anything higher than 25%, that is severe enough to where we'll talk to them about going to the chambers as well. This is what it looks like. I haven't been in it. I've been asking if they'll let me get in it to see what it's like. So I can't tell you what it feels like, but maybe one day if I come back. Next one we got here, I think we have 2 left, so hang tight. Glaucoma. So The textbook will describe this pathology as a mid-dilated fixed pupil. So if you notice the eye on our right, but patient's left, is what our glaucoma is going to look like. You see if you notice the pupil is a different size, and it, if you were to shine a light in there, it really shouldn't react a whole lot. It should be kind of fixed in that spot and size. You'll notice the conjunctiva is very red as well. Those are two kind of classic findings with glaucoma in patients, who are coming in with a bad headache. They'll probably also be describing visual troubles. Classically, it's, anytime they see a light, it's going to have like a peripheral haze around it or like a halo. That's what's described. And this is something that happens very quickly. Whether it's maybe they start a new medication that or changes the way their pupils dilate, or maybe dilates their pupil, or another classic med school test question is, they go into a movie theater, and when you go into the movie theater, there's not as much light going into your eyes, so your eyes dilate, and that can sort of trigger a glaucoma episode. And the other thing to mention, this is acute angle. You can have acute angle closure glaucoma and then open angle glaucoma. For our purposes, we'll just call it glaucoma, but this is the acute angle version. They'll have very high eye pressure, so we'll take our little tono pin and tap on their eye to get an eye pressure. It should be less than 20, but these patients it'll be almost 3 times the limit of normal. This is actually fairly rare. I don't know that I've seen a good true case of this in residency to date. And then this is our last one here. This one's also quite rare. I have seen this actually. It's called temporal arteritis. So this is a lot of times going to be someone who's coming in with a headache. Maybe they're a little older. A lot of times it's going to be someone who's female, and they will have visual troubles. They'll describe maybe some blurry vision a lot of times. But they'll have a unilateral headache, jaw claudication. So, maybe when they notice when they're chewing, they're having a lot of trouble, a lot of headache kind of right here, kind of right near their eye, on the side of their eye. And like I said, it's a lot more common in females that are greater than 50, which is actually part of the diagnostic criteria. But the big exam thing that I do for these people is their temporal artery runs right here. A lot of these patients will be very tender because they're having essentially an inflammatory process on that artery, so they'll be very, very tender if you touch their forehead there on the side. And then going through the diagnostic criteria, so they have to have 3 of these. So it's pretty. The gold standard is this number 5 here. The abnormal tab is a temporal artery biopsy. So the gold standard in the textbook is to biopsy that artery, and they put it under a microscope and see if that's what's going on. Otherwise, so in someone who's 50, they're coming in. It's really hard to say, new onset headache, because when you ask a patient, what is this a new headache? A lot of times, everyone's had a headache at that point. It's hard to say if it's new or not, if they can describe that it's a new character. But if they're greater than 50 and they're having a new headache, I'll get an ESR on these patients with just a blood draw. And if that's high, then you're meeting criteria right there for diagnosis, which is pretty crazy. And really just the treatment for these patients is steroids. The reason that this is a big deal and a big emergency, and something we talk about with headaches, is if they start to have visual loss, the visual loss is permanent. And the treatment is really just steroids for some time. So there's not a whole lot of risk to treating them. But there's, if you miss it, that's a big deal because they're going to lose vision on that side. I think that's all I had to mention there. I don't know if this will work. We can try, I suppose. Oh, very, very small. Awesome. I thought that was going to maybe open up to be larger. Here, let's see. Yeah, that's very. Can you can you all see that? Do you want me to just get out of this and make it bigger? Let's just do this. Can I just do this? Will this be okay? So this is, I just wanted to show kind of what a true seizure looks like. Is that sharing? Maybe. It says that I'm sharing. So this is pretty classic here. Wait, actually. So here you can see, you know, he's got the kind of the extension and flexion of his hand there. I'll just play this again. This is the part that I like the most, these two. So it's hard to tell here, but his eyes deviate to the side. And then, yeah, this guy, so he's got very, very much rhythmic movement of that left arm. He obviously can't, you know, answer questions or anything. This one here, very, very stiff. That hand right here, this kind of flexion maneuver is pretty classic as well, with the seizure activity. That was the big thing I wanted to mention there. And they're both very short. I know these are just kind of small clips, really, but those were the two I wanted to mention on that. And let's go to the next one. Sorry. I thought when I clicked these videos, they would just pull up in YouTube, but we'll just work with it here. This one's very short as well. So this is a functional seizure that we're seeing. So he's got a lot of kind of side-to-side head movements, which is something to notice here. It's very really his whole body is kind of side to side. It's less so the like kind of rhythmic sort of shaking. There's not really any like true kind of impressive flexion there. He also has pelvic thrusting. Like pelvic thrusting is a lot more classic with kind of functional seizures. And yeah, if you notice his arms, really neither one of them have that kind of flexion to them. His eyes are closed, or during the episode are closed. There is a part 2 of this video where he is able to answer questions right after, so he doesn't have any postictal state. So all those things being kind of, you know, certainly want to consider a functional cause. And then this last one is probably less useful, but since it's here, I'll just go ahead and show you this. So this is our myasthenia. So you can see his left eye there. He's got some pretty impressive kind of lid lag or ptosis right there. And then he'll put an ice cube on for some time. And then that's what he's looking like afterwards. So really just the ice cube alone, you know, he has the improvement of his ptosis. So that's just a neat little kind of bedside or party trick you can do to also diagnose myasthenia gravis. But that is that. And this guy talks a little bit about some theories. But anyways, that's all I have. Do you guys have any questions?
Yeah, we had a few questions come in. One was a drug question about headaches. Is there a difference or a preference between opiates and tramadol for headaches in the pre-hospital setting?
Yeah, we're not using tramadol for one. So I would not do opioids for headache at the pre-hospital setting unless there's trauma involved and you're treating other injuries.
Yep. Okay. Very good. One's a little kind of off the wall, but I'm going to ask it. Will a headache resulting from hitting head during a fall increase blood glucose?
Yes, you get a stress response from any kind of trauma or injury, so you will get an increase in your glucose. That's a reasonable question. Yeah.
So really that can happen with any
Any
traumatic
stress.
injury.
Yeah, it could be, fear, anxiety, or trauma. Yes.
And then we had a couple of people mention, I'll let Dr. Ferguson kind of address this, that, when you were talking about seizures, you mentioned midazolam at 5 to 10 milligrams IV/IM, but actually here in Alabama, our dose is much lower than that, protocols. And kind of to complicate that, which a lot of people were texting me, telling me they only have midazolam in 2 milligram vials.
Yeah, so I think the state's looking at revising the protocols. Currently, it's 2 milligrams IV for medics, IN for advanced EMTs, and I think the plan is to move it to IN or IM for the advanced EMT, but the dose is too low, right? So, 5 to 10. For Ativan, the state says you can do 0.1 mg per kilo up to 2 milligrams. In my opinion, that's probably too low for a real seizure as well. So that's being addressed by the state right now. You could probably address it through your offline medical director and maybe potentially ask the state for a variance to have standing orders for a higher dose.
Because it comes packaged in 5 and 10 milligrams.
Yeah, you got to do 5 or 10. So
Yeah.
It's all about the same price, right? And the only thing I want to say, we got to take a break. So but just remember for seizures, as a dispatch for EMS, always consider that as a dysrhythmia. Cardiac arrest until proven otherwise. I always think about getting a 12 lead on people who are post-ictal after a seizure, after you manage their airway, you do oxygenation, ventilation, you check your glucose. When they come back, 12 lead. On QT, having runs of torsades, that's the problem. And if you miss that, people die. Take a quick break, and we'll come back in about 5 minutes.
Yeah, everybody will be gone here about 5-6 minutes, and we'll be back with Dr. Wade. So stay tuned.
All right, we working? Good deal. All right, guys, so I guess we'll go ahead and get started. I want to apologize first off. I was initially going to do some time on renal emergencies. That PowerPoint and the computer it's on is probably on Facebook Marketplace somewhere in the Dallas-Fort Worth area about now. So we're going to lateral a little bit. I'm going to talk about endocrine emergencies today. This is one that we see probably a lot of out in the pre-hospital setting. A lot of kind of bread and butter EMS, like emergency medicine and pre-hospital medicine here. Spend a lot of time on kind of some common presentations, and then a couple of pretty rare but pretty deadly presentations, just stuff to keep in mind kind of as we're going around. And y'all feel free to stop me at any point. I try to keep a lot of pictures in my lectures, just because when I start putting down a bunch of words, I start getting confused. So y'all bear with me. I have no disclosures here. I'm not getting paid by Big Diabetes, although I wish I was. Just a quick overview. I'm going to spend a little bit of time on adrenal crisis, going through kind of our diabetes, high sugars, a little time on DKA and HHS, some of our pretty common stuff. And then some of our thyroid emergencies on the end, which are kind of some of our more rare but pretty deadly presentations that we see occasionally in the emergency department and kind of out in the pre-hospital setting. As we can see kind of on the side, the endocrine system is, pretty overarching throughout the body. This is all of these systems, and you'll see this kind of reoccurring theme where it's, the brain talking to an organ that's talking to the rest of the body, and there's lots of feedback loops in there. We're not going to get too in the weeds on it, though. Don't worry. Speaking of, this is kind of our basic hypopituitary. Y'all, this is way too complex. We're not going to get way in the weeds on this because a lot of these systems are so complex and interact at every single part of the body. What I try to do is break it down a little bit more simple than that. So we've got our hypothalamus up kind of just underneath the brainstem. What this does is it acts on the anterior pituitary sitting right next to it. So releases something called corticotropin releasing hormone, acting on that anterior pituitary right next to it. That says, hey, release some ACTH or adrenal corticotropin hormone, telling the adrenal glands down around the kidneys to release adrenaline, not to release cortisol. This baseline cortisol level within your body is really what helps kind of promote your sodium metabolism, promotes your blood sugar your blood pressure throughout the day, and can be really important in some of this. And you can see just based on kind of coming from the brain down to the adrenal glands, there's a couple different places where we can break this system. So let's start with kind of a case. You're called to the home, 32-year-old gentleman, there with altered mentation. Got Crohn's disease. Family said he had a recent flare and started on prednisone. He's been taking a bunch of prednisone daily, but ran out a couple days ago. Wasn't able to refill his prescription. He really just takes the prednisone 40 every day, mesalamine, and some ranitidine. There's your initial vitals on this gentleman. Heart rate looks okay. He's 68 over dead. Respiratory rate's pretty normal. It's at 95. He's pretty cold. When you go in and take a look at this guy, he's a little altered. He's not quite following commands. Maybe he'll open his eyes when you yell at him. You notice this kind of weird dark pigment throughout, kind of on the lines within his hands, maybe up and around his face, but otherwise looks okay. Get a point of care glucose, and it's low as well. Any of you guys history buffs out there? This guy is. So yeah, right. So JFK actually had this same disease, and what we're talking about is called Addison's disease, or a primary adrenal insufficiency. So in JFK's case, his sodium metabolism. So these guys actually have to take steroids chronically to try to keep that up artificially. This is one thing that we see not infrequently in the emergency department, and the problem is, unless you're looking for it, you're not going to see it. The kind of overarching theme that we'll see coming back again and again and again with this is you've got one of these axes, one of these big systems where there's some kind of insufficiency, whether that's up in the brain, whether that's at the gland itself that's releasing the hormones, and then you get a stressor on top of that really throws these guys off the rails. Most common thing, that's why I've got an underlined bunch of stars by it, is we see this a lot in people who are on chronic steroid therapy. So, a lot of your autoimmune patients around here, back when COVID was going around, we'd have people on like these super, super long steroid doses. Maybe they're shopping around different primary docs, and they've had this kind of upper respiratory infection for months and months and months, and they've been on prednisone the whole time. What happens is these guys either run out, or they get some other stressor on top of that can really throw them into this crisis. The other things we see is, as I was talking about with Addison's disease, that primary adrenal insufficiency, like what JFK had. Sometimes we see cancers up and around the adrenal glands, infections. The classic telling is like some kind of fungal infection or TB, although that seems to be less likely, especially around here. Within the anterior pituitary, kind of up around the brain as well, same deal. Sarcoid, TB can infect and destroy those glands. If you got neoplasm, you got a big tumor just kind of pushing on that thing, it's not going to work as well. And then sometimes if we've got somebody who's got head and neck cancer and we just blast their throat and kind of their skull base with radiation, we can knock out these glands and make it worse. And sometimes we're even doing it. So you've got somebody who's got some kind of insufficiency there, right? On this chronic steroid therapy, or has like an adrenal insufficiency, and they get septic or they get a bad urinary tract infection. Sometimes if they go in for surgery, or if they get in a bad car accident, their body, they run out of meds, which is not uncommon around here. Psychological stress, exercise, dehydration, pregnancy can throw people into these. And then all kinds of medications. I'm not going to throw up a list on here because the more I looked, it's a list of hundreds and hundreds of meds that can kind of induce this for these guys. What you'll see with these guys is they come in sick. They're hypotensive, usually got this vasodilatory shock, similar to like a septic shock that you guys will see. They're febrile sometimes, they're throwing up, they got belly pain. I had a patient, I think early last year, where I thought he had, a bowel perforation, because you just kind of whisk by his belly and he'd jump off the bed on you. Turns out it was one of these adrenal crises, and this was just kind of the way that it manifested. Delirium, confusion, and then they can get this kind of weird hyperpigmentation or kind of vitiligo. So, and I know some of you guys are looking like, hey, that's really not specific, which is, it is. So this is hard to pick up on if we're not looking for it. Not that it helps us a whole lot in the pre-hospital setting, but kind of some of your labs that you'll see over there, these guys will get hyponatremic, so they're just losing all their sodium. Potassium will start climbing through. The big one to pay attention to is it's not uncommon that these guys are hypoglycemic as well. So if you're seeing somebody who's shocky, altered, you get a D-stick and it's low as well, maybe keep this in the back of your brain as something that may be going on. As I mentioned, these skin findings that can be helpful with it, what you'll see is kind of on the left side right here. We've got one that's labeled May 2014. You see kind of around the underwear and panty line, you can see some darkening there in that intertriginous zone. If you're worried about it, sometimes you just, hey, take a quick look in their mouth. You might see something like this that would tip you that direction. So what do we do for this guy? Well, they're not making enough cortisone, so let's give them some cortisone. A lot of times the mainstay treatment here is just 100 milligrams of hydrocortisone. We're giving it IV, and if it's not working, give another dose. The problem is once you get that on, because they're dependent on this cortisol, you've got to redose it in about 6 hours, and another 6 hours, and another 6 hours to make sure we're keeping those levels high enough to deal with the stress. A lot of times with these guys, they have a basic amount they take at home. Maybe they take 20 of prednisone every day at home. But if they get, and a lot of times we'll know from their doctor, if they get sick, if they get in a car wreck, if something else is going on, they need to double or triple that dose to try to keep up with the body's demand. Good thing is there's nothing really new here for us in the pre-hospital setting as far as resuscitating these guys, right? It's similar to your sepsis patient. We want to fill the tank. Let's get some fluids on board. Start pressors if they need to. I love Levophed and epinephrine for these guys. Once they get to the hospital, we'll get nerdy and we'll draw the random cortisol level. Normally, it's not doing me any good in the ER, but it's helping our ICU guys or our inpatient docs once they get upstairs to help make this diagnosis. Really, what my practices lean to nowadays is, all right, we've got somebody who's sick as snot. They're hypotensive. We've given fluids. We're getting our pressor started. We're starting to max up on our Levophed or on our epi, and we're looking to add a second agent on. About that time is when I want to kind of train it in the back of your brain. Hey, let's go ahead and give 100 of hydrocort, just because if it's not going to hurt the patient getting more cortisol on board, at least in the acute phase. And if you're dealing with an adrenal crisis that you haven't diagnosed, there's no amount of pressors you're going to give that's really going to get you there. You're going to add that second, third pressor on, and you're still going to have kind of the same response. So just kind of thinking back to, hey, what level's broken? The good thing for us is the answer is typically going to be cortisol, cortisol, cortisol. Any of you guys remember this guy? So Wilfred Brimley, he had a couple of commercials back in the day where he was diagnosed with type 2 adult onset diabetes. So we'll kind of switch gears over to our diabetes. Classically what happens is you eat a big meal, right? You start absorbing all that stuff. It comes out in the sugar from the food you eat gets out into the bloodstream. Problem is just hanging out in the bloodstream. Your body can't really use it straight on. We use a hormone called insulin that's created within the pancreas that comes out in the bloodstream. It actually allows our body to absorb that blood sugar out of the bloodstream and actually use it to make energy. Unfortunately, in some people, especially kind of type 1 diabetics, you get some kind of destruction within the pancreas of those beta cells that produce insulin. And now there's no insulin floating around. Blood sugar's floating around in the bloodstream, but the cells of your body actually can't use it. So they're in this kind of chronically starved state. On the other hand, we see a lot, especially here around Birmingham and with all of our Alabama mediums around here, is this type 2 diabetes, which is more kind of this insulin resistance, where they make some insulin, but kind of hammering back on our type 1 diabetics. Most of the time, you're going to see this in kind of young people. Age of onset usually is kind of somewhere around the teenage years, although late onset that I've seen due to autoimmune disease kind of in our like 50, 60-year-olds. This is a fundamental problem of they can no longer make insulin at all. So all that blood sugar is floating around, but without insulin, they are unable to use it entirely. So they're in this starvation state unless we can get them insulin so that they can actually use that blood sugar. Unfortunately, type 1 diabetes can take a lot of years off somebody's lifespan just because it's very difficult to manage blood sugars consistently. And for most of the time, this is an autoimmune problem. Definitely be a stroke mimic, and I've seen these guys get stroke alerted. Then you're not glucose, and their glucose is like 20. I'm nauseous, throwing up, feeling terrible. They just don't quite feel right. You guys do a great job of this, is using that glucose as that sixth vital sign, right? As you're getting everything, half the time when I'm getting a report, y'all are already telling me the glucose before I'm even asking for it. It's awesome. Unfortunately, on the inpatient side, we still have to keep drilling this into kind of our APPs, into our new MDs of just, hey, check the glucose, check the glucose, check the glucose. Ask for it if you haven't gotten it, because this can be extremely dangerous for patients, and it's an easy test to get, especially with kind of point of care glucose. You guys know the treatment. They're low on glucose. Let's give them some glucose, right? You have time to get IV access, that's great. If they're able to eat something, then yeah, you can definitely just get some complex carbs in, get some orange juice on board. If they are comatose, if they are seizing on you, I'd have a low threshold to go ahead, drill these guys, get some dextrose on board, because you're going to save these guys' lives just getting that blood sugar up. So kind of moving on to another case. Forget that I misspelled called on there. It's finals time. You get sent over to the UAB dorms. You got a 19-year-old female. She's vomiting, headache, belly pain. Says she's been having like some intermittent chest pain for the last couple days. Maybe sweating, feels sick, but doing okay now. She's got a history of type 1 diabetes. Initial vital signs on her. She's tachycardic, but normotensive. Looks all right. She's breathing quick though. You go in and she's kind of satin fine though. Sweaty, looks dry everywhere. Those guys where you can kind of hear their lips smacking together from across the room, kind of as they're talking to you, that kind of dry mouth. You get a point of care glucose there, and it's just reading high. I think at UAB, our start reading high anywhere above 400. I think that might be about, y'all's might be 400 or 500 when they stop reading. What this is this is DKA, so diabetic ketoacidosis. What this is, kind of our recurring theme, this is impaired insulin or glucose metabolism plus some kind of stressor. Diabetics are going to be the ones who get this most of the time. By far and large, is going to be your type 1 diabetics, right? occasionally we can see it in our type 2 diabetics because they are just so insulin resistant that they are functionally type 1 now. You know, even though there's some insulin going around, unless they give a ton of it, they're just not able to use any of it. And it's not uncommon, especially in these younger people, you know, even 8, 9, 10 years old up into the teenage years, you'll get these new onset diabetics where, you know, they've just been feeling sick, maybe throwing their guts up, and they're in full-blown DKA and have just never been diagnosed. You'll notice, you know, these guys will be tachycardic, they're dehydrated, they look terrible. When it gets really, really severe, when they get this horrible acidosis, they get this high blood sugar, they can actually get some swelling of the brain in addition to that, and will actually develop some neurological symptoms, whether that's being super altered, they can't have like some focal deficits. It's just something to watch out for in these guys. What this is kind of this perfect storm of, you know, you can't use the glucose. They're in some kind of stress state, whether that's from an infection or they're studying for finals really hard, just went through a divorce, maybe they're dehydrated to begin with. Body can't use the glucose and it's struggling, right? It goes into panic mode. They're releasing more catecholamines. They're getting that adrenaline surge. It's causing an increased blood glucose on top of that, which makes things worse. Unfortunately, and you guys will see kind of the classic thing when these guys come in with high blood sugar is, you know, they're drinking like crazy, they're peeing everything out, but they're just super, super dehydrated, because what happens is when that blood sugar is super, super high, your body wants to kind of overfilter and over pee to try to get rid of that stuff, but it's not able to. Because they're in that starved state, they start breaking down fat, liver's trying to kind of produce some kind of a byproduct of making energy that your body can actually use. It's not glucose, but unfortunately, it's also very acidotic. So these guys will be dehydrated, they'll be acidotic. They've got this high blood sugar, they look terrible. A lot of times you'll see these guys, and it's not uncommon that, you know, they'll come in and maybe the nurse grabs me and says, hey, you know, hey, they got this kind of weird fruity smell on their breath, or hey, maybe it smells like they might have been drinking, which can kind of be hard to distinguish sometimes. What this is caused by is actually acetone that they're breathing off. Not to get too in the weeds on this, but whenever we can't use glucose, the liver starts trying to produce other energy that we can use outside of that. And it does that by breaking down kind of fat cells through beta oxidation. And what this is going to produce are these ketone bodies, this beta hydroxybutyrate and acetoacetate. And acetoacetate, when it goes out to the muscles to actually get used as kind of almost like a bypass energy source, it gets broken down into acetone and that beta hydroxybutyrate. That acetone, you can actually it actually is soluble in the bloodstream, and you breathe it off. So they get this kind of weird fruity breath smell whenever they get it. Pre-hospital, well, what do we need to do? Well, I'd say, you know, make sure we're checking glucoses. You know, I would argue just make it your 6th vital sign. You know, if you're worried about it at all, just go ahead and get the finger stick. You know, it's a cheap, easy test, can give you a lot of good information too. Most of the time, these guys are very, very fluid down, so they need some fluid resuscitation. If you've got time to hang some fluids, you know, go ahead and get it on board. You know, O2 if needed. Sometimes it can help with kind of their work of breathing, but the main problem is they're just trying to blow off all of this CO2. It's not so much an oxygenation problem. I say prepare for CPAP and advanced airway, because if these guys get severe enough in DKA, they're trying to breathe really, really hard. They're trying to keep up and blow off that CO2 so that they don't get more acidotic. As these guys get tired or as they get altered because it's getting worse, you can start to see respiratory depression, and these guys will crump very quickly. Just of note, kind of CPAP is a great option for these guys because you can increase their ventilation. They can blow off more of that CO2, and it can definitely buy you some time. Advanced airway if needed. Just know that if you do intubate these guys, instead of setting them on a rate of 15, 16 like you normally would, we're going to have that rate much higher, kind of up in the 20s, up in the mid-high 20s. Really what these guys need is a diesel bolus, right? If we're anywhere nearby, let's get them loaded up, get some initial tests going, and start hauling towards definitive care, because it's going to need a lot of resources and a lot more help. Kind of jumping into like some of the labs, some of the stuff that keeps us in there. In DKA, I'm usually starting with, a basic metabolic panel. That beta hydroxybutyrate, it's a specific test looking for those ketone bodies. A VBG, and really all I'm concerned about is, hey, how acidotic are they, right? And then looking at their urine, maybe we'll see some glucose, some protein, and some ketone bodies in there. When you check the blood glucose on these guys, a lot of times it's high, but compared to some of the patients we see out in the community, it's not terrible, right? It'll be 300 to 500. I know a lot of patients that are just walking around there. But the problem is these guys can't use any of that sugar, period. So their pH is going to be super, super low. I've seen these as low as 6.9, 7.0. They're on the edge of coding at that point. They'll have a low CO2 because they're breathing it all off. You got to watch these guys. They can be hyponatremic, so sodium will be low. The interesting thing with this, and I always harp on it with my providers, is it's actually kind of a weird lab error where when there's a lot of glucose in a sample, it kind of messes with how they can read the sodium. So the sodium will read artificially low, even though it's not. So you'll have patients that'll come in, their sodium reads 115, but their glucose is 800, and they're dehydrated, they're super acidotic, and they can't use any of the sugar, right? So kind of our mainstays of this should be get some fluids, get some insulin on board. As a really important aside to that, we have to be really conscious of our potassium when we're repleting these guys. Most of these guys are total body potassium depleted just because they've been peeing it all out. And insulin, when we give it, actually drives all that potassium intracellularly. So you can actually, if you start this treatment, start running really quick with it, aren't watching for that potassium, you can bottom these guys out pretty quick. A lot of times when I'm starting it, I'm hanging fluids, I'm going ahead and hanging some potassium with it, and I'm giving some insulin. Really the focus in DKA is, I don't really care what their glucose is, to be honest. Really what I'm more concerned about is that acidosis and that dehydration. And the way we can fix that is really getting some fluids on board, driving some of that glucose intracellularly so the body can use it and start chewing up those ketone bodies. One thing that we noted, and it's part of the, I think, Children's of Alabama protocols once they get into the ER, is if they're altered, sometimes they'll even consider using like hypertonic saline in these guys. This is not to freak y'all out or not anything to try to memorize here. It's just to know that DKA is something we've been dealing with for a long time, and depending on where you're at, it's very heavily protocolized. This is, I think, the Children's of Alabama protocol from a couple of years ago, and you can see they break it into kind of different phases, but really that initial one is hey, let's get some fluids on board, let's get some insulin on board, and check your potassium, and you're just continuing that out and kind of adjusting from there. Kind of changing directions over to like our HHS. This is going to be more common with our type 2 diabetics, right? Another, unfortunately, non-specific presentation, MIMA's diabetic. Maybe she's got some urosepsis going on, recent changes in her meds. What I want you guys to remember about HHS, or hyperosmolar hyperglycemic state, in these type 2 diabetics is this is functionally our problem, is that gooey syrup is what their blood looks like. Their glucoses will be up close to 1,000. They are severely dehydrated. I mean, this is what's pumping around, and it's very difficult for the body to use that appropriately, especially up and around the brain. Kind of highlighting some of our key differences here, right? In HHS, our primary problem is they're just very, very, very dehydrated. That blood is like syrup. Meanwhile, on the DKA side, it's more, we have all these ketone bodies around kind of creating this acidosis. In DKA, I'm not really worried about what their glucose is. I just want to fix those ketone bodies and close the gap. Meanwhile, on HHS, I want to really control and kind of rehydrate them, and that's going to be our mainstay therapy on it. Obviously, with both of these, you can definitely see some cerebral edema. You can definitely see some weird electrolyte abnormalities. And then kind of note is with DKA, this can happen pretty quickly, especially if you've got somebody who's a type 1 diabetic who runs out of insulin. But on the other hand, HHS, true HHS in type 2 diabetes actually develops weeks, even up to months at a time. the good thing with that is, well, because they got there over a long period of time, we've got some more time to try to fix this too. So we can take our time with it. So kind of our mainstay of treatment there is going to be fluids. If you really want to get nerdy about it, you can even calculate a fluid deficit in some of these guys once you get some initial labs, and some of them can be as high as 10, 15 liters down. So they are super dehydrated, really watching their electrolytes while they're there. A lot of times, we probably don't need to get an insulin drip on these guys, and it's probably not necessary to try to slam in, a big dose of insulin on the way. And, we can get some long acting on board and really just concentrate on getting in the fluids and getting their bloodstream a little less syrupy. So never try to keep us on time. On the throat. Think of this like the gas pedal for your body, right? So this is gonna control metabolism. It's gonna control heart rate. Can control kind of your like your body internal body temperature, appetite. Really plays into a lot of different systems within the body, and we don't really have time to cover that, and I don't think it's really necessary for us. But when the system gets really out of whack, it can cause a lot of problems. This is kind of my simplified version of the thyroid axis. So kind of similar to before, we've got the hypothalamus up in the brain talking to the pituitary gland hanging off of it that releases our thyroid stimulating hormone that goes down to the thyroid and tells it to release thyroid hormone. T4 and T3 are just two different kinds of thyroid hormone that we follow pretty closely in the ER. T3 is your more active of those, and those are going to act out in the rest of the body at all different sites to basically control this. But I want you guys to think of this. This is the gas pedal for the body, kind of controlling how quick or how slow everything is moving. So kind of coming on to our to one of our last cases. I think we got one more after this. Family called 911, got a 45-year-old gentleman at home. He's confused, febrile, short of breath, having a bunch of diarrhea. A lot of times thinking, hey, maybe this guy's septic, maybe he's just super dehydrated, what's going on? Walk in the room, this dude's just staring a hole through you, right? Get your initial set of vitals. He's hot, 39.4 Celsius, tachycardic, breathing pretty quick. His pressure doesn't look terrible. He's sitting kind of borderline, kind of 89%. What this picture is describing on the side is called exophthalmos. It's these bug eyes where they're just sticking out. These guys are sweaty, tachycardic, tachypnic. What this is thyroid storm. So this is a severe hyperthyroid, and a lot of times can be caused by whether it be infection, whether it be some autoimmune disease. Maybe they're just taking a ton of their thyroid medication that can kick this off. The reason why this is important to keep in mind is it's got a 90% mortality no matter what we do. These guys are sick as stink whenever they hit the door. You get this severe hypermetabolism, so they're sweaty, they're febrile, they're tachycardic. These guys are super high risk for like weird cardiac arrhythmias. They can be super agitated, almost can seem like they can be on like some pathomimetics, where they're on like can almost look like an amphetamine overdose, can look like a cocaine overdose. These guys can get like weird resting tremors where they're shaking all over the place and actually can even develop into seizures. Kind of as I mentioned, it can be a lot of different medications that can cause this. DKA, sepsis, amiodarone is a common drug that a lot of people are on that can kick this off. And then if they've got a new thyroid mass that's just spitting out a lot of thyroid hormone, that can also kick them into DKA. These are some of the lab tests we look at. The TSH, if you guys remember TSH and T3, T4, this is like our normal thyroid panel. And really the thing to note here is our free T4 and free T3 are high, right? So we're overproducing here. And actually that works on a negative feedback loop to have to tell the pituitary and the hypothalamus, hey, slow down, don't produce as much TSH. And it's doing that. So your system's working right, but you can see at the very bottom, we're still producing too much thyroid hormone, probably from some other, whether it be a mass or them taking some medications. Really, what our management is once they hit the ER is going to be stopping the peripheral effects of it, blocking kind of our production of the thyroid hormone and preventing any further release. Rebel Reviews, this is a group out of Canada that I love following their stuff. Or no, they're Australia, sorry. Really our basis is going to be getting propranolol, esmol, some kind of beta blocker on board early. What that's going to do is help stabilize that cardiac membrane, prevent some of those cardiac arrhythmias, but also is going to help decrease that peripheral conversion of the thyroid hormone. PTU and methimazole are other things we'll give in the ED just to kind of help stop thyroid hormone production, and then giving things like iodine, steroids down the road. Usually I'm just titrating this propranolol to effect just until I get them slowed down enough that I'm comfortable. So our last case for the morning, 65-year-old female, nursing home patient. She's here, altered mentation, bradycardia. She's got a history of a couple strokes, hypothyroidism. She takes aspirin, takes her Synthroid. Nursing home has no idea what's been going on for the past couple days. On exam, check her pulse. It's slow. She's about 41. Blood pressure 70 over palp. She's super cold to touch, minimally responsive. Maybe she's kind of groaning at you every now and then. You're thinking about intubating her, maybe waiting a little bit. What this can be is something called myxedema or myxedema coma. What this is as opposed to the thyroid storm, right, which is where we're slamming on that gas pedal, everything's moving really quick. This is the opposite, where the gas pedal's gone. We're not getting any throttle. Extreme hypothyroidism. So you get this hypometabolic state. So they're cold, they're slow, they're bradycardic, they're breathing slow, they're hypotensive, shocky, altered. Problem is, this is a lot of the patients I feel like we pick up from these nursing care facilities, especially when they're older, and did they take too much of their beta blocker? Did they take too much of other meds that can kind of be driving this? I put the pitting edema on here, which, unfortunately, especially here in Birmingham, we see a lot of patients with edema, right? These guys will have edema everywhere. It'll be on their feet, in front of their tibias. You can see it on their face, and underneath their eyes, they'll have kind of pitting edema all over the place. Let this kind of increase your suspicion for it. Your initial treatment for these guys is, well, they're low on thyroid hormone. Well, let's give them some thyroid hormone, right? Let's try to hit the gas pedal a little bit better and get them supported. But other than that, the treatment for this, at least until we can get some thyroid hormone on board, is just supportive care, right? If they're not breathing adequately, well, maybe you need to take that airway. If they're hypotensive, get some fluids on board. Go ahead and start some pressors. See if we can support them from that standpoint. If they're hypoglycemic, getting some sugar on board. So kind of coming back to basics as far as initial management of these guys. But one of those that is easy to miss if you're not thinking about it, and patients can have really, really bad outcomes. So I know that was kind of a whirlwind, kind of going through a lot of stuff. What questions do y'all have right now? Chief Ward, any questions from online?
Yeah, we got a couple. So I think most of the questions we've had have actually been about adrenal crisis.
Mm-hmm.
So we've got a state protocol for adrenal crisis that involves Solumedrol.
Mm-hmm.
And I think most of our questions are revolving around, hey, how does Solumedrol help? What's the mechanism?
Yeah, and so what Solumedrol does is you kind of get a mix of this kind of mineralocorticoid and glucocorticoid. So really what it is it's artificial cortisol, kind of acting on two different levels. And kind of similar to the hydrocort that I kind of reach for in the ER is really what we're trying to do is just replace that cortisol, because your primary problem is they're not producing enough cortisol either at all, or they're just not producing enough for that stress state. So it can be definitely helpful. It's one, I think one of the more important things to get on board early.
All right, good deal. Yeah, we had a few questions related to that. We also had one person ask if you thought it would be a good idea. I think I already know the answer to this, for us to carry insulin in the pre-hospital setting. And I think shelf life and other things probably.
Yeah, I think that's the problem is, like, on one hand, logistically, insulin can be difficult to keep up with. It can be very expensive. A lot of times, that insulin in the moment isn't going to be the thing that really saves these guys before we can get to definitive care. I think a lot of times we're really supporting them as best we can before we can get to, because we're not going to be treating DKA or HHS completely out in the field. It's one of those, it's going to take days and it's going to take a lot of resources. So really kind of the more we can kind of stabilize them in the moment and get them to definitive care is probably going to be better.
Yep. So another question is, we've traditionally been taught, that lower concentrations of dextrose is better for children who are hypoglycemic.
Mhm.
And what's the rationale behind that, if you know, or if you could speak to that?
Yeah, you know, this is kind of me spitballing, but I think a lot of times in these little kids, their vasculature really doesn't tolerate those really high concentrations as well as older people do. You know, if you think about it, you're giving a very thick and a very kind of irritating substance in the veins. If you're giving it in a large vein, say in like an adult-sized human, you can probably, you can get around that a little bit and they can tolerate it better. In those teeny tiny little veins that we get on kids, you're probably going to give way too much glucose, and it's probably going to be just really, really irritating to the vasculature there. You can get away with D5, D10 just fine with these little kids.
All right, very good. So a couple more things related, I think, primarily to diabetes. One is, if you have a patient with altered mental status, at what glucose level do you kind of attribute their altered mental status to hyperglycemia?
So, man, hyperglycemia, that's hard, right? Because a lot of the times the glucose isn't really what's driving it. Kind of as we were talking about before, it's the glucose typically isn't the problem. It's either in HHS, it's that they're just so dehydrated and that blood is just syrup, versus in DKA, it's because they have so many ketone bodies floating around that maybe they're starting to get some brain swelling. So I don't know that I would necessarily drive it off of the glucose level, as I would kind of the clinical picture of it. And in the pre-hospital setting, especially, I would kind of preferentially reach for kind of some fluids before we're getting to kind of really hammering down that diagnosis.
Yeah, I think part of what they're getting at here is a lot of times we'll have somebody with altered mental status, we really can't figure out what's going on with them.
Yeah.
And you do a D-stick and it's 280.
Yeah.
And I think generally speaking, from my experience, from my point of view, is I'm not going to attribute the primary cause of altered mental status to hyperglycemia until it's super high.
Yeah, absolutely.
Otherwise, I'm going to keep looking for another cause. Would you agree with that?
No, yeah, completely. And that's the hard thing, especially with our patient population here, is there's a lot of people just walking around the streets with blood sugars of 300, 400. So it's it's helpful. Blood sugar is one of those. It's helpful if it's 40, and it's helpful if it's 1,000. But kind of that in between area, it's difficult to really hang your hat on.
Yep. All right, one more. It's related to metabolism too. It's an interesting question. So a lot of people are currently on super low carb diets and becoming ketotic purposefully, even measuring it every day and that sort of thing. Through restriction of dietary carbohydrates, is it possible for people to create any type of medical emergency due solely to elevated ketones?
Yeah, that's a difficult one. It's in the setting of a normal insulin axis, in the setting of normal glucose metabolism, it's hard to get into ketosis enough to really throw yourself into a medical emergency unless you're just severely starved. When we get into trouble is if you've got someone who is already very insulin resistant, if they're a type 2 diabetic, or if they're a type 1 diabetic trying to do these, where kind of like we were talking about before, what you need is you need a deficiency within the system itself and then a stressor on top of that. So I would think of the low carb diet as a stressor, but if you've got a normal intact system, it's going to be much more difficult to get into a medical emergency kind of in that setting. Not to say that it's impossible, but much less likely.
Very good. Excellent. Hey, appreciate the great lecture, Dr. Wade. Appreciate Dr. Hubbs for the earlier lecture. Just a reminder to everybody, please fill out one of our attendance forms. There should be a link if you're online that you can click in the Q&A box. The past password is renal. If none of those mechanisms work for you, you can send an email to alabamaemschallenge@gmail.com. You'll get an automated reply with a link to the attendance form. Thank you very much for joining us. We'll see you in 2 weeks. We'll be coming to you from Albertville, if I'm not mistaken, 2 weeks from today. So look forward to seeing everybody then. Take care.